All right, so continuing on with chapter 16, we're talking about some of the pathophysiology behind an acute myocardial infarction. So, an AMI can have three serious consequences. Um, the patient can die from a sudden death where there's no hope of fixing or catching what's going on. They can go into cardiogenic shock, which we talked about in a previous lecture, and then they can have congestive heart failure, which starts backing up that fluid into their lungs as well. Some of the reasons for sudden death is that the patient may actually go into a dysrhythmia, which is an abnormality of their heart rhythm. Some aren't so harmless, others cause immediate death. So the ones that not so bad, premature ventricular contractions, also known as PVCs, are just extra beats because the heart is irritated. It can be from damage or just from being hypoxic. Um, this is pretty common among healthy people as well as sick people. Um, really, truthfully, not um, dramatic in and of itself. The more frequent that the PVCs are occurring, the more irritated the heart itself is. Tachycardia is a rapid heartbeat beating at 100 beats per minute. Typically not going to be a huge problem unless they're beating so fast that their heart is not filling adequately between beats, and then that ends up decreasing their cardiac output. Bradycardia is a slow heartbeat at 60 beats or less per minute. Typically, if they're around 60-ish, it really doesn't bother them too much, but once they start going so slow that their cardiac output is no longer adequate to meet their metabolic demands, then now all of a sudden we start having side effects that we can see in a patient, but as a right away is not a life-threatening dysrhythmia. Ventricular tachycardia comes in two different flavors. We've got VTAC with a pulse, and we've got VTAC without a pulse. And it can transition from VTAC with a pulse to pulseless VTAC very quickly. This is when the bottom part of the heart is beating anywhere from 150 to 200 beats per minute. And the faster that the heart goes, the less it allows for filling between those contractions. If it's going so fast that it's not filling at all, your heart's still pumping, but no blood is getting pushed forward. No blood gets pushed forward, that results in sudden death. The other rhythm is ventricular fibrillation. Ventricular fibrillation is very disorganized. Instead of actually beating, your heart is more quivering than anything else. And that's because so many different parts of your heart are trying to fire at the same time, and it's just, there's no coordination whatsoever. So this immediately ceases blood flow through the body. The patient becomes unconscious within seconds. Really, the only thing that's going to save them at that point is going to be defibrillation. Defibrillation doesn't necessarily restore the cardiac rhythm. What defibrillation does is it tries to terminate the irregular rhythm so that the heart can resume a natural organized rhythm. Defibrillation can save lives. However, you have to have a life there to save. So doing CPR, high quality CPR, as you learned in the CPR course, is actually the biggest lifesaver for somebody. If you don't have a heart that's viable or a body that's viable, defibrillating is not going to do anything. So you have to do high quality CPR right out of the gate to give that person a chance. And that's unfortunately what doesn't happen oftentimes when somebody goes into cardiac arrest out in the field. In the hospital, yeah, they have a great survival rate with CPR, medications, and defibrillation. Out in the field, often there's unknown downtimes. We have no idea what the history is of the patient. And so while we teach everybody that they need to know how to do CPR because it can save lives, our success rates out in the field definitely not as great as we would like. So asystole is the final rhythm that your heart goes into, which is the absence of all electrical activity. It's not technically a flat line. A flat line is when you don't have any electricity at all in your heart, and you have the leads off. Your asystole, while it looks a little bit like a flat line, you still have a little bit going on. But asystole is when a patient has been ischemic for quite some time and they've got nothing going on. Nearly all patients that go into asystole will die. There are some special situations in which we would still continue to do CPR on somebody that's in asystole, namely somebody that has experienced a cold water injury or severe, like cold environmental. We say that a person is not dead until they're warm and dead. A body being that cold can actually sustain itself. It essentially freezes. If you want to think about cryogenically freezing somebody, it kind of does that and it reserves all of your bodily functions. You just have to warm it up to get it started again. Cardiogenic shock, we've talked before, but we'll just kind of review a little bit. So cardiogenic shock is often caused by a heart attack. The heart lacks the power to force blood through the circulatory system. And this is typically going to be because parts of the heart are injured and don't have the ability to actually contract anymore. But this causes an inadequate oxygenation of bodily tissues downstream because the heart can't pump anymore. It's more common if the MI is affecting the inferior or posterior region of the left ventricle. And it's really important to recognize shock in its early stages. Congestive heart failure often occurs within the first few days after an MI. And then it develops when an increased heart rate and enlargement of the left ventricle no longer are able to compensate for a decreased heart function. So once you start having problems with parts of that ventricle dying, what's going to happen is your heart's going to try to compensate by increasing the size of the cells that are still alive and increasing your heart rate to try and compensate. And when that no longer is able to keep up with the demands of the body, or it doesn't have enough force to push past that peripheral, that systemic vascular resistance, then things start backing up. It's called congestive because your lungs end up taking up a bunch of fluid once your heart fails to pump effectively. And then it can also cause dependent edema. This is when the lowest part of your body ends up starting to collect fluid. If you have left-sided heart failure, that goes to the lungs. Eventually, after enough time, your left-sided heart failure can lead to right-sided, or you could have a right-sided MI that does the same thing, and that's where the fluid is going to start backing up into the body. Hypertensive emergencies. So hypertension is high blood pressure, and when we're starting to get into the systolic pressure greater than 180 millimeters of mercury, or if you have a very rapid increase in systolic pressure, this can cause a hypertensive emergency. Often the first sign is going to be a sudden severe headache that comes on. Others, a strong bounding pulse, ringing in the ears, also called tinnitus, nausea and vomiting, dizziness. Warm skin can either be dry or moist. Nosebleeds, those vessel walls in your nose are very thin, and so if you increase pressure too much or too quickly, kind of blows those out. A sudden development of pulmonary edema. Untreated hypertensive emergencies can end up leading to stroke, hemorrhagic stroke, or a dissecting aortic aneurysm, which are obviously life-threatening. So transport to the hospital as quickly and safely as possible. You may want to consider ALS, though there isn't a whole lot that we can do as ALS providers anymore for this. There was a medication that we used to use, but we don't use that out in the field commonly anymore. An aortic aneurysm is a weakness in the wall of the aorta, which is susceptible to rupture. If it ruptures, the blood loss that the patient ends up having will cause the patient to die very, very, very quickly. A dissecting aortic aneurysm occurs when the inner layers of that aorta become separated, which allows blood to start pooling in between the layers because of high pressure. Uncontrolled hypertension is the primary cause of an aortic aneurysm. Signs and symptoms include very sudden chest pain that's located in the anterior part of the chest or in the back right between the shoulder blades. Pain that usually comes on full force from 1 minute to the next. So as things are beating, it's becoming different and painful. Sometimes there's a difference in blood pressure between the arms or diminished pulses in the lower extremities. Bottom line, this patient has to go into surgery very quickly or they will die. Here's how to differentiate between a myocardial infarction and a dissecting aortic aneurysm, kind of the differences in the pain. And your pain with your aneurysm is going to be where it is on the aorta. If it's more on the arch of the aorta, it's going to be up in the chest. If it's more on the descending portion of the aorta, thoracic, still going to be in the chest, probably a little bit in the abdomen. If it's more lower in the abdominal aorta, abdomen, and then into the back, and the lower it goes, the more symptoms you're going to have lower down. So it kind of sticks along the same track. For a patient assessment, we start with scene size up, just as with anything else, determining the nature of illness to try and help yourself along with determining what's going on with your patient. You want to form your general impression. If your patient's unresponsive, not breathing, go ahead and begin CPR. We start with chest compressions now, and then call for an AED. You guys as EMTs can utilize an AED. And even if you have just a monitor, a manual monitor, there is an AED mode for you to utilize. Then we're going to go and assess airway and breathing. If the O2 sat is less than 95, go ahead and apply oxygen. Typically, we say go ahead and go big or go home. We can always turn it down. If their patient is not breathing or they're breathing inadequately, go ahead and start assisting ventilations. If the patient has signs and symptoms of pulmonary edema, you may need to assist positive pressure ventilation with a BVM or start the patient on a CPAP. If you start with low oxygen, if they're pretty close to 95, so you start with a nasal cannula. If they don't improve, keep improving how you're applying that oxygen. You want to make sure that the patient is having some positive turnaround because they're having issues with oxygenation. So we need to make sure that we're taking care of that. Circulation, we're going to check the pulse, skin, color, temperature, text, capillary refill time, and then consider treatment for cardiogenic shock early because the heart is not able to pump forward. Put the patient in a position of comfort. Usually they're going to be better sitting up and well supported, and then make sure you make a transport decision early on. Whether you were able to stabilize life threats or not, if you have life threats present, you're going to want to go ahead and transport as quickly as possible and then complete your secondary and history taking in the rig if possible. Most patients with any sort of chest pain should be transported immediately just because we don't know. We can't do that definitive treatment to say, yes, this is definitely what it is or what it's not. As a general rule, try and transport the patient with cardiac problems in the most gentle, stress-relieving manner possible. Don't have them walk long distances to get to the cot or to get to the ambulance. We don't want to increase their anxiety or that myocardial oxygen demand.